good afternoon. Here we are. Guess what time it is? Wow, we are 1 minute late. Don't tell anybody, but great to see you. I'm Dr. Randy Fink, and it's Fertility with Fink and Friends, live from Colorado Springs, where I am the clinical director of IVF services here at CNY Fertility, Colorado. And like we are every Tuesday afternoon at this time, Fink and Friends is the place you need to be. So let's settle down, relax, and plan to spend a little quality time together doing the things that we do the best. Talking about things that are important. We've got all kinds of nice people joining here. So a special hello going out to, let's see, who is our number one? Looks like Ross Johnson, the number one right here on, this is CNY's Instagram. Over here on my Instagram, we have Rosa SD, along as well as, all the other great people who are here with me. Hello to Bimbo Gunlay. How are you, ma'am? Nice to see you. My crazy three boys are here. Hope, Love, and Pray 619. Special hello to Lisa Mullins, to Amber Vince in Kentucky. A very special greeting goes out to Brandis Montez, our wonderful nurse practitioner here in Colorado Springs. Amanda Marie, hi. A special hello to Jody. Thank you so much for being here. Lovely Onyx, good to see you today. Jamie Marie, Ariel, we've got Elise Marie, Mallory, Antonia looks like. Ariel says, hello from California, planning to do my second egg retrieval in a few weeks. I'm in Colorado. Marcia in Miami, my very special friend. Thank you for being here this afternoon, or actually this is evening over there on the other coast on our friends on Facebook. Hello to Neri. Thanks for being here today. We have a special guest, by the way. I am Fink, you are Friends, and that is why we call it Fertility with Fink and Friends. But joining me in our Colorado Springs studio today is a very good friend of mine, a wonderful colleague, someone who many of you may have met before if you've done procedures here in Colorado. But would you please allow me to welcome the one and only Ryan Rohla. Ryan, welcome to the show this evening. Ryan is a nurse anesthetist extraordinaire here at CNY Fertility, and is going to talk all about things pertaining to anesthesia. So certainly if you've got, we'll try to get to all your questions tonight as always, but if you've got questions about anesthesia, this would be a great opportunity to ask them. Special thoughts go out to all those people who are suffering with very hot temperatures, high temperatures in our country tonight. Those along the Texas coast dealing with the storm cleanup. I spoke to a wonderful patient this morning who told me all about what they're going through in terms of a couple of feet of water in the basement. And I will tell you that I moved here to Colorado from South Florida. So I experienced the same thing with Hurricane Irma, 3 feet of water downstairs. We were without power for about 2 weeks. The generator ran constantly. So our thoughts go out to you. Those of you dealing with the heat, man, it's hard to even imagine. But here in Colorado, I think it was about 52 degrees this morning. Our highs are about, I think, maybe 78 or 80 degrees, nice and dry. And it's unbelievable that the weather has been so incredibly favorable right here, but so difficult in so many other places. Aside from that, Ryan, where are you from?
I'm from Wyoming.
You're originally from Wyoming,
yes,
and you're a nurse anesthetist. Exactly what is a nurse anesthetist? Is it a type of a nurse or?
Yeah, so a nurse anesthetist is a type of nurse. You take the nursing track as opposed to the medical track where you would be an MD doctor. The training is very, very similar. It's the exact same training. It's just a different track. Like I said, you go one way nursing, the other way medical.
So you went to nursing school.
Correct. Yep.
And did all those things that nurses do.
I did.
You worked in a hospital setting, right?
Yep.
Nurse anesthetists in general have to have some time in the ICU. Is that correct?
Correct. Yes. So you have to start out with getting your bachelor's in nursing. That's the very first thing, the first step. After your bachelor's in nursing, you have to get a job. A favored position would be working at a level 1 trauma medical center, hospital. I actually worked at the University of Virginia Hospital in their medical ICU there. And you get a minimum of 2 years experience. Mostly it takes people about 5 years experience total before they start applying for schools. Schools will start looking at you around that period. Once you get into school, your program can be anywhere from 2 to 4 years of just specialty anesthesia training. And with that, you'll end with your doctorate in nurse anesthesia.
So that makes you that degree. The letters behind your name are CRNA. What does that stand for?
Certified Registered Nurse Anesthetist.
So you stand up there at the head of the table and watch every breath our patients take.
That's correct.
Yeah.
I'm there for every breath. I love this position that I get to play in every field, whether it's the OR or whether it's a clinical setting. You get to monitor the entire patient. You're watching vital signs. You're looking at how medications you're giving are affecting that patient, and you're working with the doctors and you're giving them what they need. You know, what depth of sedation you need to be providing. My favorite part is working individually with patients, because every patient is different. Every person is different. So, you know, you have patients with a little bit more anxiety about whatever it could be. So you're just trying to deal with multiple things, whether it's anxiety, whether it's pain, whether it's something mental going on with them, something physical going on with them. You get to deal with it all.
I think people in general are very fearful of pain.
Mm-hmm.
And certainly, you know, when folks are coming in to our process here at CMY, let's say for an egg retrieval, they're often worried about, you know, they're worried, is this going to hurt? You know, am I going to be, you know, is something going to be humiliating? Am I going to experience pain? And then, of course, secondarily, it's, well, and you know, how many eggs am I going to get? Am I going to make embryos? Am I going to end up getting pregnant? Is this process going to work? But that fear of pain, I think, is somewhat universal. And I certainly know that, you know, as an obstetrician, when I was delivering babies, you know, the fear of pain associated with labor and delivery is a very real thing. Can a childbirth experience be pain-free?
Well, that's the goal in some instances. What we do here is very different from childbirth. When you're delivering a baby, if anesthesia is coming in, hopefully it's for an elective procedure, which we call regional anesthesia, which would be either an epidural or a spinal before a C-section. The type of anesthesia we're doing here is called sedation. So I'm giving medication through an IV that's actually affecting the patient's brain. It's making them sleep the entire time. In the hospital, you're not really affecting the brain with the medication that we're giving. You are affecting pain receptors in specific parts of the body to where you are numb or you're feeling less pain in those parts of your body, but you're still awake. You're not sleeping. Here, you are sleeping. And, you know, I've heard stories of people that said, you know, I've heard somebody that had a surgery and they were awake and they were paralyzed the entire time and they weren't able to speak. And that's a little bit more severe of a procedure that you're explaining to me. Number one, we're not doing anything to where I'm paralyzing any patients. What we're doing is we're monitoring your vital signs the entire time. So if you are experiencing any signs of pain, it'll show me on your vital signs. Your body responds to the pain the same way you mentally do. When you say, ow, your heart rate's going to go up. Your blood pressure is going to go up. These are all signs that I'm watching every single second of these procedures.
So even though somebody's asleep, if they're experiencing pain, you can tell.
Yeah, absolutely. You can totally tell when they're experiencing pain.
And this sort of brain sleep that we're talking about, is this the same kind of brain sleep that we have at night when we go to bed, or if you work nights in the day when you come home from your shift?
It's not. It's a little bit different. The type of sleep that you're getting when you're sleeping at night is a natural REM sleep. What we're doing here is I'm giving you medications to put you in a sleeping state. It's not as deep, which would be considered the REM type sleep. It's a lot lighter than that.
So the sleep that we have here, sedation for a procedure, is not as deep as the sleep that you have at night.
No, it's not. However, when patients come in and say, you're super nervous, you haven't slept the night before, the second I give you those medications, your body responds to it and it goes to sleep because it realizes how tired you actually are. So in those cases, they actually are getting a pretty deep sleep. It's just because your body's responding to the lack of sleep the nights prior. But just a normal person waking up at a normal time, getting average rest, the type of sleep that I'm able to provide is not as deep as the deep sleep you would get on a nightly basis.
So the sedation goes through the vein.
Goes through the vein.
Right.
Yep.
Do you think, and I guess you folks out there who've been through it can share with us your experiences. Is it something that people remember?
I would say for the most part, no, people don't remember much. What they will remember is they'll remember the setup before I actually give the medication. They'll remember, okay, I know that we talked about going to sleep. I remember you explaining what was about to go on and how I was going to feel, but that's basically it. That's the extent of what a patient usually remembers. Patients, also I ask, did you dream about anything? Patients won't even remember their dreams in the most cases. They'll say, I think I dreamt, but I just don't remember it. So that period from once I give you the medication to where you're waking up, it's kind of a lost moment in time. It's like a freeze, it's like me hitting a remote control and just hitting pause on you. And then as soon as you wake back up, the play button is hit again. And it's like you didn't even realize that you had gone to sleep yet. A lot of people will wake up and they'll say, are we done? I
can't believe it. Yeah, right.
Yeah.
We're actually done.
Exactly. So it's interesting how the brain works. It's almost like you just kind of pause that moment right before that medication gets into your system and starts activating.
Let's talk a little bit more about regional anesthesia. So this is something that hopefully everybody who is with us will be able to experience a pregnancy. Now, many people decide that in labor they don't want pain management. And I think that's, in my experience, that's certainly everyone's option. It might not be what I would choose for myself, but the one word of advice that I have there, I would often see folks who would say, no, I've just decided I'm not going to do that. I want to be as natural as possible. I just want to do this natural. So I've decided I'm not going to have anesthesia. When faced with the kind of pain that's associated with labor, it's really hard, I think, to be able to say, I just decided I'm not going to do that. It's something for which I think you really do have to prepare. And if you prepare, I think you can do it. But regional anesthesia or an epidural, you are placing that into the back, right?
Correct. Yep.
And it's numbing people. Is it paralyzing them?
No, it's not paralyzing them. And a lot of people's fear with epidurals is they are like, you're going to stick a gigantic needle in my back, and then you're going to give me medication. The way that we place an epidural is very comfortable for a patient for the most part. You start out with using the smallest needle possible with lidocaine inside of it, and you put it just under the skin and make a tiny little, what's called a bleb. And this is the point of entry that you're entering in. And once that lidocaine is in there,
lidocaine is numbing medicine.
Exactly. That's correct. So the lidocaine is numbing that spot to where we're going to place our needle. So the only part of the epidural that you should feel that's painful is the actual, just that little needle going in with the numbing medication going in. Once that's numb, the larger needle can be placed and you can find the spot that you're in. Now, when you're looking for the spot, sometimes patients will feel tingling in different areas of their body, or they'll feel a little kind of like a zinger. But it's not a painful process by any means. So I think that's the biggest thing, is people think that it's going to be this super painful process where you're going to be sticking needles into my back, and I don't want that.
Well, and in my experience, really the more uncomfortable part is that you're trying to catch them between contractions.
Yes, correct.
Right. So,
correct.
So there is an underlying, there's a lot of pain that's going on anyway that you're trying to make go away. Well, once that medicine goes in, does it work immediately?
No, it takes a little bit. It takes a little time. We do checking of different levels of where it's going. But that's another thing too, is if you have a plan for an epidural to be placed, that's almost the better way to go, because once you're having tons of pain and you're having, contractions, it's a lot harder for something like that to be placed and be effective. If it's in place prior to all that, we can manage the pain with the medication and use different dosings.
Well, and so talking about working quickly, let's say going back to the type of sedation that we use during egg retrieval here, how quickly do you expect it to work? Do you have to dose it and then you wait 20 minutes for it to kick in, or how does that work?
It's very fast. And everybody that is new to anesthesia or that procedure or that process is super, super surprised at the speed of which it is. The second that medication hits the vein, your body is feeling it. Your brain is telling you, oh, there's something in my body. So the first sensation that people feel is they'll feel like a little bit of warmth in their arm where the medication's going in. Secondly, they may get a funny taste. So it's kind of the medication just working its way up through the body in a sense. They'll get kind of a funny taste in their mouth, or they'll have kind of a funky taste in their throat, or a weird feeling. And then their face starts to tingle. Once they start feeling that tingling in their face, that is kind of the body's sign of like, okay, that you're about to go to sleep. This entire process takes about anywhere from 4 to 8 seconds. So it's very, very fast. And, some people will like to try to do a countdown, and, some people like to try to fight it or whatever. But I kind of find the best way to do it is just embrace it. And it's a point in time where you're going to be taking a nap. So just to kind of think about, a dream that you want to have. Think about a vacation that you want to take. This is an opportunity. You're going to fall asleep. So use that mental choice and say, okay, I'm going to start thinking about a beach now. Or I'm going to think about the mountains. And
very nice.
And just kind of concentrate on that.
Hey, a special welcome back, I guess I should say, here to all of our Instagram friends on CNY's Instagram. I am getting some messaging that for the first few minutes there, I guess that was the first 18 minutes of our program, there may not have been any sound going on the CNY Instagram here. So if you're just joining us on that side, my Instagram is Randy Fink MD, and this live will be posted on my Instagram, where you can go back and reference what we were talking about there in the first part. This is Ryan Rohla, nurse anesthetist here at CNY Fertility Colorado, and we are talking about all things fertility and anesthesia. Let's see if we can jump into some questions. I see we have some questions for general fertility things, but I see there's a few here from the Facebook side for some anesthesia things. Alicia says, where to go here, Alicia? Because I think I saw that first. She says, you did the anesthesia for Alicia. You made her feel so much less anxious before falling asleep. So that is awesome there. Ryan is also a specialist at deciding and helping you determine what sort of music you like to hear as you fall asleep. And so we get to all enjoy that music together as you sleep during your egg retrieval. And I saw that I got to come back to where was it, Alicia? I remember we turned on Coldplay, I told you my chest was warm, and you said that's normal. Then I was out. I woke up ready to take on the world. I've seen people at the office come out loopy and tired, though. Is everyone different? How does that work?
Yeah, so that's a great question. Everybody's body processes the medications different. So if there are any issues with your body, say, there's problems with your kidney, problems with your liver, if you're taking certain medications, these can all affect the drugs that I'm going to be giving you during the anesthetic. The other thing is the length of the procedure. So the longer you're asleep, the longer it's going to take for you to be fully awake. So if you have a relatively short procedure, you're going to wake up feeling great and you're a healthy person. If your procedure is stretched out over an hour, 2 hours, and you don't have the healthiest liver, or your kidneys aren't functioning as well, it's going to take you a lot longer to wake up. So everybody's body is different. And that's why the schooling that we go through is so important, because we're looking at so many different factors that come into play with the medications we're using. We're using the same medications, but because physiology is different in each individual, it's very important that we look at every single aspect of what the patient presents to us.
Anna is over here on the Instagram side and said, I just had my CNY baby and I had a spinal with Duramorph. I immediately started vomiting and vomited through my C-section and for 10 hours afterwards nonstop. I also felt like pins and needles all over my whole body. And kind of while they did the C-section, is that a normal reaction?
So it can be. It's not a normal reaction, but it is one of the side effects of those medications. Sometimes with Duramorph, it can give you really bad itching as well. That's a
Right.
that's a more
Itching
common,
is a big one.
That's a more common one that I see. The vomiting is a side effect of that medication, but 10 hours worth of vomiting is pretty extensive. That kind of leads me to think there may have been some other thing, blood pressure possibly could be in play a little bit. But, I don't know. It's just different with each individual person.
Well, Becca is here also on the Facebook side and says, my husband's anesthesia got messed up. So I'm kind of terrified about this. I think it's perhaps a universal phenomenon that when folks, just like sort of being fearful of pain, that many people have a fear of kind of being out of control, of being put to sleep,
Yes.
where they're not electing to go to sleep. And how do you counsel people about that?
Yeah, absolutely. And that's an issue that a lot of people deal with. It's just kind of that loss of the control that you have over yourself. So the most important thing for me to provide to that patient is to explain what's going on. Every single thing that I'm doing, how they should feel, how they should be feeling. It at least gives you that sense of like, okay, I know what to expect now. And when I feel that, it's okay because I'm expecting it. So it kind of gives you that control back a little bit in a sense. But the fact, back to the question about how her husband had a bad anesthesia experience. Those are my favorite cases to do because I like to, get the entire explanation of what happened prior, so I can almost fix it in a way and find what was wrong, how they did it wrong. In a lot of aspects, what it comes down to is maybe, that it just wasn't like that provider didn't look at a certain aspect or they didn't ask about a certain thing. And so it's really important for me to know everything about my patients before they go to sleep, whether good or bad, so I can provide a good experience for them. I love when my patients wake up and they say, that was the best nap ever, or I was so scared about this. And it was easy. It was super easy. That's like the most comforting feeling I can have as a provider and as a human.
Yeah, indeed. And Elisa asks, will I wake up all loopy or just tired?
It depends. Some people will wake up, they don't really wake up loopy necessarily. A lot of people will wake up tired and sometimes emotional because of the hormones that it's in such flux during these points in time. Your body doesn't really know how to respond when it wakes up always. And in these cases, I'm giving you medications that are kind of messing with signaling in your brain, mixed with, hormone variability. Sometimes people are emotional, whether that's a happy emotion, whether that's a sad emotion, whether that's, laughing. They're usually going to show a type of emotion, but they're not loopy. They know what they're saying. You might not necessarily remember everything you said, but the things that these patients say, it's nothing out of the ordinary for the most part. It's pretty just, it's an emotional response. So sometimes you'll see crying, sometimes you'll see laughing, stuff like that.
Do you have a favorite kind of music you like?
Oh, I love every kind of music.
And he does, actually. He loves every kind of,
kind of music.
There's not a song. Sometimes we've had people say, I would like to listen to Hannah Montana when I go to sleep. And Ryan's like, oh, I know the whole catalog.
Yes,
So,
yes,
right.
yeah.
And he does know Hannah Montana. Montana.
Yeah, absolutely.
All right, let's see. Let me throw a couple of questions here just for some of the general things. Can you talk a little bit about epigenetics? Epigenetics is well, we're choosing to use the donor egg route. My husband is sad that the baby won't share my traits. Well, I would dispute that. This comes from Jenny. The baby will share some of your traits. So with a donor egg, an embryo that's created from a donor egg, we know that every drop of blood that goes through that baby will be yours. There is no question that that is your baby. Epigenetics tells us that there are a series of little switches that are all turned on or off in any particular order based upon the environment in which that embryo is growing. Meaning to say that your uterus determines many of the features of your baby. So yes, hair color, eye color, those things are going to be programmed by the genetics. But things like, is your baby going to be, the examples I always use, will your baby be artistic or mechanical? Those things are going to likely be because of the uterine environment. Will your baby like to color with crayons or markers? Will your child sing in be a tenor or a baritone? These kinds of things are programmed by the switches that are on or off in whichever given order that are based upon the environment in which that embryo is growing. That's what epigenetics is. So there is no question, Jenny, that that baby is yours. What can I do for nausea and diarrhea? I'm in the first trimester. Well, first of all, lovely Onyx, congratulations on the pregnancy there. So nausea is a common problem in pregnancy, and the best studied medication is a combination of vitamin B6 and Unisom. Unisom is a sleeping pill. And so you can actually it's all over the counter. It's 25 milligrams of vitamin B6. And I think now I'm actually forgetting the exact dose, but you can get a vitamin B6 tablet and you can take a half a Unisom tablet. That is manufactured pharmaceutically in a drug that's known as Bonjesta, Bonjesta, which is one of the best studied medications in the history of medical science in pregnancy. It is unequivocally known to be safe, and it has a very dramatic effect on nausea and vomiting in pregnancy. And as for diarrhea, Imodium is fine for you to take during pregnancy, and will stop that horrible diarrhea. Be here soon from Texas. Looking forward to seeing you. Linda Wynn says, waiting for my next cycle to start my next FET. When do I start the L-arginine? So there are 5 supplements that you are supposed to be on for embryo transfer. Okay. Prenatal vitamin, CoQ10, vitamin D, vitamin E, and L-arginine. These things you start on actually you can start on them anytime that you know you're going to be gearing up for an embryo transfer cycle. So as soon as you know that, go ahead and start on those supplements. So the sooner, the better. Ideally, if you're on them for at least a month, then you'll be doing yourself a favor. Chop and Guardian. I couldn't pronounce that last week either. I'm so sorry, but hello from California. Did your baseline and fingers crossed. Yes, indeed. There's Brandis saying, yay, Ryan. She doesn't say yay, Randy, but she did say yay, Ryan. Okay. Whatever. Okay. Alyssa Marie says early miscarriage with the first trimester. 1 embryo left, trying the immune protocols. Is a 5BB a good quality, and should I try a modified natural? They say about embryo transfer cycles, you've got your options. You can take a medicated cycle, which is the way that most of the cycles in the United States are accomplished. And that's where we give you all the estrogen and progesterone, and we are suppressing your body's ability to ovulate and to make those hormones yourself. We're giving you all those hormones. We are controlling every variable so that nothing is left to chance. That's the way it's been done in IVF since IVF was invented. So 40 years, they've been doing medicated cycles. The natural cycles, the modified natural or the outright natural, or what we'll call an ovulatory cycle, these are at least as good. And some studies say they are even better, that there may be a little higher success rate, maybe a little lower miscarriage rate. So yes, I think it's definitely reasonable to do a modified natural cycle, Alyssa Marie, and a 5BB is a pretty good quality there. And so now quality of embryos and embryo grading really doesn't correlate too much with outcomes. So it's a beauty contest. We generally tell people don't pay too much attention, because a very poorly graded embryo could absolutely positively give you a perfect, beautiful baby, whereas your most beautiful embryo may have a series of complex chromosome abnormalities that if you were doing PGT testing, you might see. So the grade is really not critical. So I'd say, yes, you should feel very comfortable with that embryo there. Let's see what else we got going on over here. So Callie says, my thoughts about an HCG wash. Was supposed to have my transfer with you guys next week and was asked if I wanted to do the wash and the boosters. Pros and cons. Can you do the boosters without the wash? What are your thoughts? Okay, so if you're doing a medicated cycle embryo transfer, HCG boosters are really not helpful. So I do not recommend them under that circumstance. HCG in the body becomes more progesterone. In a medicated cycle, we're giving you huge amounts of progesterone, so you really don't need any more. Not so helpful. The HCG wash turns up some of the receiver antennas inside the uterine lining. So yes, I do recommend an HCG wash. If you're doing a natural or a modified natural cycle, then an HCG booster is very helpful. And in that circumstance, I do recommend it. Lindsay said had her second transfer yesterday with Brandis, and you love the staff so much, and we love you, Lindsay. Thank you very much for saying your kind words. Again, my apologies. We're halfway through our episode of Fink and Friends here today, which Ryan takes to calling the Fink Fertility Fun Show, but Fertility with Fink and Friends. I am Fink. He's a friend. Yeah, how about that? Yeah, that's a good thing. Sorry about the sound problem on the CNY side. Earlier, we recouped some of our viewers, but never quite got back up to where we normally are. So I think a lot of people saw it wasn't working and then just tuned out. So if you know any of those people, this broadcast will stay on my Instagram. That's Randy Fink MD. So please feel free to take a look. Is it possible to get an epidural if you have scoliosis? I've heard somewhere that you can't.
Yes, that is not a good idea to give an epidural in scoliosis.
Well, I think it depends on how significant the scoliosis is, right? If it's something that's very minimal, then it may not be an issue. Yep. But if it's very severe, what's the risk there?
So what is going on is with your scoliosis, it's moving spinal canals and spinal cords. And these are the things that we're trying to avoid, is hitting a spinal cord. So if you are trying to get into a specific spinal space, you're using a straight needle. And if that space is moved, in a curvature, you can't access it with a straight needle. And we don't use those types of needles that have curves in them. And so you could actually end up causing a lot of damage to a person by puncturing the wrong thing.
If that scoliosis is severe enough. Yeah. Anna asks, is it true that after taking an epidural, bad back pain is a side effect?
After, where was it at?
After using an epidural.
Oh, back pain.
Yeah. No, I think the answer to that is no. Here's been my experience in pregnancy. So first of all, in pregnancy, your body changes so very dramatically. Your center of gravity changes. You've got a big belly here from a baby. Each breast may be bigger and may actually weigh more than your arm does by the time you're at term. So you've got a lot happening in the front part of yourself that's changing the mechanics of how you stand. Not only that, hormonally, the joints are getting looser. Your pelvis is trying to accommodate a baby coming through. So those looser joints are more associated with musculoskeletal injury and pain. Combine that with the change in the center of gravity, where muscles in your back that are holding you upright are suddenly having to work harder than they ever have really in your entire life. They're having to do things that they never had to do before. It's very normal that even without having had regional anesthesia for your delivery, that you're going to have pain after you have the baby. So I see a lot of people with back pain after having had a baby, and they say, oh, I think it must have been from the epidural. But I see just as many people who didn't have an epidural have that same kind of pain. The other thing to remember is that, when you're pushing in labor, for lack of a better expression, your ankles may be behind your ears. Your pelvis is really flattened out like this to try to open the space of the pelvis in order for the baby to be able to come out. So that's not necessarily a fully natural position that you're used to most of the time. I think, am I correct that consequences of an epidural resulting in back pain would be very rare and serious?
Yes, correct. That's correct. Also, what I was going to say with that too is when you are pregnant, going through a pregnancy, your blood volume increases. This increase in blood volume actually engorges the spaces in your back. So you can have discs that are, slightly herniated or out of place a little bit that are getting pressed on a lot more because that whole space is just engorged and it's larger. So people sometimes will feel back pain just from the enlargement of the space in between those discs.
That's an interesting point. Awesome. Let's see. AZ Sunshine says, is Dr. Kiltz not the doctor for Colorado? No, Dr. Kiltz is in Syracuse. He is the owner of the company. CNY Fertility is his baby, so to speak. But I am the doctor in Colorado. My name is Randy Fink. Rosa says, Ryan is so wonderful. Rosa, you say all the right things. That's very, very kind. Let's see. Going back over, Ryan is the best. That comes from Laura Lou. Hey, Ryan, we had a lovely chat about UGA football and Kanye West. You made my egg retrieval so fun.
That's great. Thank you.
What is, let's see, I guess this one's probably for me from N. Griffin. What's your opinion on Orilissa for endometriosis treatment? So Orilissa is a great option for suppressing endometriosis, and it does improve our outcomes for embryo transfer. So strongly recommended. I think it's a lot easier on you than the older alternatives like Lupron, which shuts everything down. Now, as far as treating an endometrioma, which is a collection of endometriosis that's actually in the ovary that we can look by ultrasound and see that endometriosis in the ovary, I would not expect Orilissa to have a significant effect on the size of that endometrioma. However, what it does, we know now that endometriosis interferes with the way the brain talks to the uterus by creating an inflammatory marker in the uterine lining that's known as BCL6. BCL6 is actually something that we can test for with a test that's called Receptiva. 60 days of Orilissa or Lupron, or the other medicine is called Myfembree. What that does is that it shuts off the BCL6. It decreases the inflammation in the uterine lining, so it significantly improves the outcomes of an embryo transfer. So, yep, I feel pretty good about that. We'll hopefully be doing a retrieval with you guys. If you see 3 follicles at baseline, what are the odds of other follicles showing up once starting? The odds are generally pretty good. So what you're talking about is what's known as an antral follicle count. And that's a count of the number of follicles at the beginning of the cycle. And it is often predictive of how well you'll do with the stem. But just because you see 3 follicles at the beginning of the cycle doesn't mean that you're only going to get 3 eggs to grow in the ovary. So be reassured, generally speaking, about that. This comes from Nurtured Shanna, an anesthesia question. I had low blood pressure and was very woozy following my second retrieval. I had to be wheeled to the car. Any suggestions to feel better immediately following my next retrieval?
Yeah, absolutely. So usually in those cases where your blood pressure is very low, it's due to dehydration. Not only is it very high altitude here, it's very dry here. So the thing that I would say to help for next time or next time you're having anesthesia is the day before, just make sure you're drinking a lot of fluid, staying hydrated, try to get a good night's sleep or try to get some good rest. And I think that would take care of it for the most part. That sounds kind of like just an issue where you were very dehydrated. And that's a way that we try to bring your blood pressure up immediately, is just try to give you fluids. But I'm sorry that happened to you. I definitely say next time though, make sure you're just drinking a lot of fluid the day before.
Amanda says, Trevor Hall all day.
Nice.
Brittany's asking about ovarian PRP, one that usually requires anesthesia and one that does not. So what I favor is intra-ovarian PRP, and that is where we are actually taking your platelet-rich plasma, we're drawing a tube of blood from your arm and preparing that to separate out your body's healing components, your tissue factors, your growth factors, and literally injecting it into your ovaries. This causes some remodeling of that tissue and is said to be where some of that benefit is. Now, ovarian PRP is an experimental procedure, so we're still learning an awful lot about it, but that does require anesthesia because it's a needle going through the vaginal wall via an ultrasound probe and into your ovaries. Something that we at CNY call high volume PRP is where they take probably, double that volume of PRP and place a little catheter in the cervix and inject it into the uterine cavity. And it is said to spill out the fallopian tubes and bathe the ovaries. That can be done in a clinic setting or in an office setting. There are some of our doctors at CNY who feel that is a better way to go. My personal opinion is intra-ovarian PRP, but you will always find differences of opinion where there isn't strong science to the evidence yet to back it up. But over time, more and more evidence every day really about ovarian PRP. So that's the difference. Intra-ovarian PRP is something to get a little sedation for so that you don't have to feel that. Becca is actually telling us a little bit more about what happened with her husband. He got some local anesthesia, but he felt every single thing. They didn't wait at all. They gave him the meds and started not even 5 minutes afterwards. So the local anesthesia, when you inject it in, have you guys ever had, some numbing medicine, maybe ever had to have some stitches or something like that? It burns when you put it in. Yeah. Why is that?
It's just a difference in pH going into your body. It's a different pH level. It's a little bit more on the acidic side, so you're going to feel it burning and going in. The reason that the local wasn't working for your husband was it wasn't correctly placed around the specific nerve that we're looking to target. A lot of times when we do regional anesthesia or blocks, you're targeting a specific spot with an ultrasound, and your needle is guided with ultrasound, kind of like what we're doing here. We're using ultrasound guided needle things. And same thing with this, you're looking for a specific nerve. And what you do is you bathe that nerve in the numbing medication. And once that nerve is numbed, it actually numbs the entire portion that nerve innervates.
Now, if I inject you, let's say that we're going to put a stitch in you right there, and I inject, that goes to work pretty quickly, doesn't it?
That does go to work pretty quickly.
Now, I think something that maybe everybody can relate to is just about everybody has had some numbing medicine in the mouth. If you've ever had to have a filling or if you haven't, God bless you. You've done well for yourself. But everybody knows what it's like to get some local medication kind of in the, in the mouth. We all hear these stories about, they just kept putting more and more and more local, but I felt everything that they did in there. Are some people immune to that local anesthesia?
They're not necessarily immune to it. What their body is doing is their body is breaking down the medication at a much, much faster rate than a normal person's body is doing. And so for those cases, like what he's talking about in the dentist, pretty much the only way to get dental work, if you are not able to get numb and your body's processing through that medication that fast, is to go to sleep, which is kind of like what we're doing here. When your body's asleep, you're not sensing that pain in your brain. You're not feeling anything. And so I'm able to put people to sleep to have that dentist do his procedure, get everything done without the need to have that area completely numb. He'll still put numbing medication, but it wears off really, really quickly, and we use other medications intravenously throughout the body to control their pain.
So it's not something that they're actually immune to. So
No.
really, local anesthesia should be able to work for pretty much everybody.
Yeah, and there's another instance where local anesthesia won't work, and that's if there's a really infected region of the body. With infection, it changes that pH balance, and so when you're injecting the local, it's not working as effectively, and so you're not able to use a local anesthetic. So yet again, you go to an IV method.
Chef Blackney asks, and this is probably for me, I think, do you prefer Gonal-F, Follistim, or Menopur for
Definitely.
stims? Do you prefer a combo of Menopur and Gonal for low AMH? Well, so what Menopur actually is, or at least it was originally, all right, get this. If you didn't know this is a good story. Menopur is what's called HMG, human menopausal gonadotropin. And what that means is that it was originally extracted from the urine of menopausal nuns in Italy, believe it or not. Nowadays, I don't think they have a big truck of urine from leaving not the monastery, the nunnery, the place where the nuns live. They don't. They're not collecting. There's not a porta potty for nuns anymore. I can go on all day like this. Actually,
I like it. Keep going.
Just don't step on any of the tubes that run on the floor in the nun place, because it may have urine in it. But no, so menopausal women have a high level of FSH, of follicle stimulating hormone. And so that's what Menopur originally was, that it was FSH extracted from the urine of menopausal nuns. And then they added a little bit of the HCG derived LH hormone, luteinizing hormone. So what we do predominantly at CNY is to use FSH in the form of Gonal-F or Follistim. And to be honest with you, I think they're really the same. Sometimes insurance covers one. Sometimes we can get one cheaper than the other. I really consider them by and large interchangeable for the most part. And we use HCG-LH, which is considerably cheaper than the Menopur. Why is it cheaper? Well, you have to chase nuns for a long time to get them to pee. So it's a very expensive proposition. So, a bottle of HCG-LH is probably $130 or so that will last you for the entire cycle, whereas Menopur is typically about $80 or $85-ish or so per vial, and you may be using anywhere from 1 to 3 vials per day. So it gets expensive, right? I do think in some scenarios, Menopur has some advantages, but for most folks, starting with HCG-LH is generally okay. Now, for very low AMH, sometimes we don't even need the LH hormone, and there's a couple of protocols that I use personally that may be able to eke a little egg out of someone who might not otherwise be able to create one, that don't use LH at all. So in Europe, in the European protocols, they don't use any LH. So you have some different kinds of of options there. Sorry again about the sound. Gosh, a lot of folks saying we can't hear you. I wonder if it was on in the beginning and then it went off. Yeah, and then somebody said, okay, it's not just me who can't hear. Yeah, I think we lost a bunch of people there. So sorry again about that. Time felt so long after retrieval. I remember I was asking the nurse how long I was asleep. Once I woke up, the nurse said, I remember asking the nurse how long I was asleep for once I woke up, and the nurse says, I didn't fall back asleep. I was awake. So yeah, I think you kind of lose track of, you lose track of time, and it's not an unpleasant situation, especially when someone else is taking care of you. And that's a hard thing for a lot of people to know that you're being taken care of, but it's not a bad thing to know that no one can expect anything from you. No one can be texting you and expecting you to answer back. Nobody can be asking you to take the trash out. Nobody can be telling you to cook dinner, do the dishes, or any of those, or finish that report for work, or any of those things that life demands of us. And so it's nice to kind of just be able to get some sleep and know that you really are being kind of fully taken care of. That's my opinion anyway. Let's see, a special hello also to Angela in Minnesota. Minnesota. Oh yeah, because I always want to say Milwaukee. No, Minnesota. Thank you. I'm good. And Angela says, "Thank you, Dr. Fink and Ryan, for taking such wonderful care of me during my egg retrieval. You are absolutely the best providers." And she is now about 16 weeks pregnant, or thereabouts, if I have the timing correct on that.
Wait, what was that one?
Hi from Los Angeles.
Zero nausea.
There we go.
Zero. Shout out to Ryan for zero nausea after egg retrieval. So if we know that a patient has a propensity for being nauseated, you can actually prevent that, really, can't you?
Yeah, there's a lot of things I can do to help prevent nausea. The most important thing with it is the preemptive, me knowing that you get nauseous with anesthesia. If I know that, there's a lot of steps we can take to prevent the nausea. There are a couple of little medications that we will give that can cause nausea in people that have a tendency to lean more towards it. So I always begin my anesthetics with giving anti-nausea medication just in case. But if you are a person that has that propensity, then just let me know. And there's a lot of things I can do to help prevent the nausea.
And that same thing holds true for really no matter where you have a procedure, whether it's fertility, whether it's surgery, whether it's getting your tonsils out, whether it's getting tubes in your ears, or any such thing. Let your anesthesia provider know that you have a propensity for nausea, because really post-operative nausea and vomiting is something that we, by and large, can prevent if we know about it ahead of time. Is there some truth to folks who are prone to being motion sick in the car?
Yep. Yeah, there are. Those folks have a tendency more to get nauseous during what we call general anesthesia, which is anesthesia where we're placing a breathing tube in a patient and getting you really sleepy. These are for like the big procedures in the hospitals. If you do have motion sickness, all of my patients that have motion sickness will usually use a scopolamine patch. It just goes behind your ear. I usually use that to start with. These procedures here, I've never had to use a scopolamine patch. We can prevent it with IV medications, but with the general anesthesia, there's a couple extra things you kind of need to do, especially with somebody that has motion sickness.
Let's see. I thought that was an anesthesia question, so forgive me for getting stumbling a little bit. Does having low testosterone during your FET, like while you transfer and after the transfer, is that bad? Is there anything I should be doing? Not so important necessarily for transfer, but a low testosterone can be associated with diminishing egg quality for egg retrieval. And that's why one of the things we do, especially for folks who have diminished ovarian reserve, is that we have you on DHEA, which is a precursor to testosterone. And that dose is 25 milligrams 3 times a day. Have you seen that Randy Fink book that's called the Vitamin Victory. That includes all of the evidence-based protocols in a succinct enough fashion that they're easy to find. $7 for that ebook, and you can get that through my link tree. That's linktr.ee/RandyFinkMD. If you forget that, it's the link that is in my bio on Instagram, RandyFinkMD. But DHEA 25 milligrams 3 times a day is probably one of the more important supplements that we recommend for folks with diminished ovarian reserve, principally because of that reason, because it all ties together with the way your body makes estrogen from testosterone. Hello from Los Angeles to Andre. Nice to see you as always. And David, good to see you as well. Lauren heard the sound from beginning. So Lauren Rohla, that name sounds familiar to me. How do I know that name?
It's weird. It is very familiar.
Wait, Rohla. Who do we know by that name? Ryan Rohla, Ryan Rohla, Ryan Rockin' Rohla, and Lauren is his beautiful wife. Thanks for watching.
Hi, honey.
Mallory says, "I wish I could go to the Colorado office." You can, my friend. Come on.
Absolutely.
Yeah. Is there any word when CMY will be coming to Southern California? I don't have an answer to that question. Hey to Equestrian, nice to see you. JM Dot said, "I had a reaction to the general anesthesia used during my laparoscopy for endometriosis and ended up in the PACU overnight." PACU is the post-anesthesia care unit, so that's what we call the recovery room. My oxygen desaturated and my vitals were elevated. No previous issues with general anesthesia. What sort of things caused that?
Okay, so let's see. Go back to the question. I just want to read it one more time.
General anesthesia, desats, and elevated vitals.
Okay, so because it was laparoscopic, the way that the surgeon is able to access that is they inflate your abdomen with a bunch of air. So your body is not used to being stretched at all. And so number one, that's a lot of things that patients don't understand is that, like, I have all this pain after this procedure. Well, that's because your muscle tissue has been stretched over a period of time. Sometimes that air can leak into different parts of your lungs or like around your lungs to kind of cause you to have a little pressure on them. Also with anesthesia, it causes your body to not want to take a deep breath. So a lot of times when you're coming out of a bigger procedure or a procedure in the hospital, you're not wanting to take that deep breath in. So you're taking these tiny little breaths. You actually take more of those breaths to compensate for the fact that you're not taking one big deep breath. Because you're not deep breathing, your oxygen usually drops, and it's usually more difficult for you to get oxygen into your body. So they'll put supplemental oxygen on. They use what's called a nasal cannula. It's a little thing that goes in your nose and just delivers oxygen through that. The elevated vitals, that's kind of what I was thinking with the pain, possibly, if you were having pain. And then the low O2 desaturation could just be maybe you were just taking a little bit longer to wake up and you weren't deep breathing and taking those big, deep breaths.
That would be my guess. Probably not deep breathing. And you know, especially when things are done in the hospital, things relative to surgery, things about pre-op and post-op, you know, safety is always going to be job one. And even though a laparoscopy for endometriosis is a relatively minor procedure in the grander scheme of things, now granted, they can still be big, you know, surgical cases, but they're going to treat even the most minor procedure just the same way they do for an open heart surgery or a brain surgery. You know, safety is always job one. And I think, you know, especially in the recovery room, if there's any question about your recovery, they would much rather be conservative, keep an eye on you than send you out and have to worry about what happens at home.
Exactly. That's the last thing they want to do is put you at risk when you're at home. And leave that responsibility to a loved one. They're trained professionals, so they want to make sure everything looks perfect before you go home.
Anna's asking about an incompetent cervix. I have an incompetent cervix, and if I conceive twins, is a cerclage sufficient to hold it. Let's just talk about that in our last moment or two here together. Incompetent cervix means that the cervix, which is the opening to the uterus, muscularly is unable to stay closed, and therefore the pregnancy can just sort of fall out. With an incompetent cervix, I wouldn't want you to conceive twins because that, creates a very high risk situation, and you run the risk, of course, of losing both babies. So certainly I would say, under no circumstances would I suggest, or rare circumstances would I suggest that you transfer more than one embryo if we're doing IVF. A cerclage is a stitch that's placed in the cervix to try to help keep it closed. What's known as an elective cerclage is much better than an emergency cerclage. Outcomes are always better. And cerclages can be used in twin pregnancies with that history, but Anna, I would certainly hope that you have one baby. And that's what we're after here, really one baby at a time. Well, folks, we are going to run out of time here for the day. A very special thanks to Ryan Rohla, nurse anesthetist here at CNY Fertility, Colorado. Thanks for being here, man. It is always a pleasure. It's a pleasure to work with you, to see the way that you take care of our patients. Ryan is beloved. He is about the highest quality you can get, even though the man obviously needs a shave. But on that note, remember, every step forward with kindness. The world is not a kind enough place. Every step forward with love. And each day is a new venture in hope, because as the sun comes up, we know that tomorrow is a new day and brings about all new things. This is not the story of your life, this fertility business. This is just a chapter. And what are we doing? We're rewriting it together. Until next week, Dr. Randy Fink from CNY Fertility, Colorado. Thanks so much for being here, and good night.